Oh, well, this one, does MRI imaging replace the need for biopsy? That's an extremely perceptive question. We are actually, myself, Dr. Klotz, and the group, Dr. Fleschner and Princess Margaret, we're doing a study exactly on that purpose, to see if MRI can eventually replace biopsy. The group in Britain doing similar things. What we're doing actually, just to tell you briefly, these are people on active surveillance. They have prostate cancer, they're Gleason 6, PSA less than 10, and they've been screened properly, they're being observed, and normally we would do a biopsy in a year. Just make sure that the cancer hasn't gotten out of hand, make sure we didn't miss something in the first place. So this is what some of you are probably on right now, so-called active surveillance. Well, what we're doing is, remember there's a randomized trial, the idea of randomization is to make sure there are no other biases. Well, we're testing MRI, but rather than just doing MRI and not doing a biopsy, we're doing MRI and biopsy on one group and the other group just getting just their standard biopsies. So in the end, this group with the extra MRI, we're hoping to get extra information to answer that question that whoever this person, gentleman or lady said, does MRI replace the need for biopsy? I don't think it will replace the initial biopsy, but it will help to identify where things are and whether it's going to actually give us further information where to target it. A couple more, I think. Good. At what age should a young man with a family history of prostate cancer begin to be tested? Very good question. Some people say around age 40, instead of 45 or 50, maybe at age 40, but at least get one PSA and see where things are, and get the family physician to keep track of things. We're not advocating that everybody should have PSAs or everybody should have treatment, but at least if you know, then we can make an informed decision as to what to do about it. Even if you do find cancer at a later date, and if it's small amount, Gleason 6, then we have the options. We have the luxury of making the decisions. So yes, probably should be checked a bit earlier than someone that does not have a family history. What is the role? What's the best diet after radiation? I mean, in terms of there are a couple of things I can address. I'm not sure what the main question was, other than there will be some problems with radiation, diarrhea, possibly some bowel problems. So the main thing is to make sure the bowels are soft, make sure they're not constipated, that then it doesn't get extra stress to the system if the person is constipated. If the stools are really hard and you have to push and strain, may cause more rectal bleeding and so forth. So basically that. In terms of cancer, the diet for cancer, whether it's radiation or surgery or active surveillance, whatever, it's basically the same. It's basically a healthy, balanced diet that has less of the, say, the so-called unhealthy parts, the fatty foods and animal fats and so forth, more fruits and vegetables, and where there's things that are rich in lycopenes, rich in antioxidants, and all those things are good, supposedly good, although I don't have details on any of those, but that's for anybody. Okay. So, but as far as the bowel part, you may have to supplement it with stool softeners. Okay, which treatments are not covered by OHIP? Well, the ones that I covered earlier, the HIFU is not, if it's a primary treatment. HIFU, remember, I showed you Maple Leaf HIFU, Can-Am HIFU, those are companies that are out there individuals doing them. That's not covered. Now, when I do it, I don't charge patients for any of that stuff because they're done through a clinical trial. I have some funds from research projects, research grants to cover those particular areas. The very last thing, the intraurethral, the heating one that I showed you, again, that's not covered at the moment. Again, that's also, thanks. That's also right now is covered through it's a grant, it's a research grant. You are not allowed to charge, you cannot charge patients because it's a research program. Robotic surgery is covered as technically is radical prostatectomy. Now some places, I'm not sure about some of the places in Ontario. I know in BC, for example, at Vancouver, where they have one of the robots, they are actually asking the patients to supplement. Remember I told you there's a instrument kind of equipment fee. Each case it's about $2,600 or $2,800 more than what you would have for a regular prostatectomy. In BC, they're actually asking patients to I don't know if it's voluntary or not, to actually pay that difference. So I guess there are different systems, but generally robotic surgery is considered radical prostatectomy. Thanks. So it is covered. Radiation should all be covered. I think that's about, well, some of the investigations, for example, what Dr. Trachtenberg is doing with the lasers, I actually don't know how he's getting that through. It should be a research thing, but I can't answer that. Okay. Okay. This one, back to the 40-year-old with a family history. What PSA levels would you expect, and what PSA number would you be concerned? Good question. It depends on the size of the prostate. You know, I just off my head, I actually don't have that actual graph to show you 40-year-old PSA. If it starts out at 1.5, it's probably still okay. But if it takes a bit of a jump, then it's. And what level would you expect? 1.5. What number would you be concerned? Well, it's not, again, one number, but probably a trend and how quickly it goes up. So within 6 months or a year, there's progressive increase, then I'd be a little more concerned. I'm sorry, I don't have the exact answer for that one. Castration-resistant prostate cancer. This is, for those of you who are not familiar with this, for someone who's been on hormone treatments, and if the hormones eventually are starting to fail, so we call that castration-resistant cancer. So are there new treatment options available? Yes, there are. There are lots of options now. I can list them, but including some of the that are actually from actually the company that's helping us, sponsoring us. So there are different compounds that are available. There are newer ways of delivering hormones. It is still a hormone treatment, but newer ways to do that. And there are chemotherapy drugs that are available. I mentioned the hormones. There are stronger hormones. So there are, right now there are about 3 or 4 options. Some of them are still under investigations, but your physician may be able to help you access, be part of a clinical trial, depending on where you live and what treatment facility you're associated with. Okay, so by and large, they are effective, but they're obviously they're not home runs. They're not going to cure all prostate cancer, but they are much more promising than, say, they were like 10 years ago. Even chemotherapy, years ago, we didn't have any chemotherapy. Now there are some chemotherapy drugs that are quite helpful. This is a fear of a lot of people, and it's a very legitimate question. Can a biopsy spread the cancer when the needles are removed? Theoretically, maybe. But I could tell you, there are zillions of biopsies being done every year, every day, there are lots of biopsies being done, and there, if we thought that there was going to be tracking and spreading the cancer with the needles, you would theoretically see evidence of that later on and through, near the rectum, near the, between the rectum and the scrotum and those areas. The answer is we never see that. I guess never say never, because I have actually seen a report, but that's only on someone who is extremely high grade, very, 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 very aggressive cancer, and this is one report out of, again, zillions of people. These are, if it happens, it's so rare that you guarantee that whoever the physician is or the surgeon is, would have reported it. Okay, so again, this would be so rare that theoretically, you never say never, but it's, you could say it's a concern, but I wouldn't use that as the reason for not getting a biopsy. Now, there are other organs, other places, other types of cancers that work differently, that behave differently. But I'm just talking prostate. So that's my answer. How often should PSA how often is PSA to be tested? How often should it be tested? Well, it depends on the individual, depends on family history, depends on your race, whether you're Caucasian, African descent, Asian descent, and so forth. Depends on the family history I mentioned, and age is a big factor. Currently, say after 75 or so, if may not need to be tested if you really don't have too many other risk factors. But okay, so if PSA is in the safe range, does it mean that there's no cancer risk? Well, no, it doesn't, but it means it's unlikely. Again, PSA alone shouldn't be taken in isolation. That's where PSA got its bad name. PSA, people think, oh, PSA is inaccurate. That it's even lots of physicians say that. Family doctors come, or patients come and say, oh, my family doctor tells me don't bother doing it because it's not accurate. Well, it's very accurate. Actually, the number on that piece of paper is very accurate. If it says 4.28, that particular day, your PSA is 4.28. So the number is very accurate. Really, the question is, what does that 4.28 mean? What does it imply? If you think that 4.1, 4.2 has to imply cancer and 3.9 is not cancer, then you're wrong half the time. So that's where people initially thought. That's the misconception that PSA definitely is black and white, that certain numbers mean something. Well, you really have to interpret that in the context of the whole range of numbers, the trend, how the prostate feels, how big the prostate is, whether there's been infection, whether the person has had different sexual activities the day before ejaculation, whether he's been riding a bicycle, long bicycle rides can raise the PSA. There are lots of factors. If you just had a biopsy, the PSA is going to go up quite a bit, and then it comes back down. I mentioned infection like prostatitis. That's a big thing. So, but even in the very low range, it still doesn't mean that it's completely risk-free. I hate to make it more complicated, but there are some prostate cancers, actually the most aggressive ones, in fact, make very little PSA. But that's pretty uncommon, but you would know about it because there'll be other signs. It feels different, and the prostate feels different on rectal exam, and it behaves differently. So we rarely miss those, but occasionally we do see people who have very advanced cancer, and their PSAs is rather low, but that's very rare. But I guess if you're asking for some reassurance, then I think basically it's best to have a trend and have it the family physician kind of help you and get it interpreted in the context of both the size of your prostate and your history and so forth. And then, and again, the other thing is age too. Age is a very important factor. So a PSA of 6, for example, at age 42 is very worrisome, whereas PSA of 6 at age 78 is not too worrisome. So, okay. The last one? This is the last one, the ultimate one. Does it mean size of prostate has been reduced if PSA level has changed from 12 to 8? Well, possibly. I presume this gentleman maybe was using has been prescribed one of the medications, like either finasteride or dutasteride. Finasteride is Proscar, dutasteride one of those two drugs. So in that case, the idea was to shrink the prostate, and the PSA will drop if one of those two drugs or that class of drugs is being used. And we actually expect the PSA to drop appropriately by about half. So it was starting at 12, it should drop to about 6. Now, if it doesn't go down to 6, then you worry a little bit more, and is there still something going on? Now, if the person hasn't been on those drugs and the PSA has dropped and it stays down, then you wonder if his real baseline, so-called baseline, is actually 8 rather than 12. And that 12 was actually kind of a spike that happened for whatever reason before that you didn't know, infection again, or previous activity, sexual activities, or biopsy, or whatever, that actually made it go up, and then it came back down. So two numbers is, it's useful, but still not that great in terms of complete interpretation of the whole picture of that individual.